Thanks, Leanne, and thanks everybody for coming today. So we wanted to keep this practical and succinct. Obviously, which scan do I order to cover everything is completely impossible in this time frame. So I've chosen a smattering of areas where I think it's either interesting because there's topical issues flying around in the media perhaps, or things that I think are generally not as well done in terms of asking for the right tests, but also keeping it to the really important common things. We're not going to talk about esoterica today. So basically the question is, which modality will give me the answer? That's what we're trying to address here today. And what are the options? MRI, CT, ultrasound, plain films, bone scan and SPECT CT. I'm not going to spend a lot of time on nuclear medicine because, to me, like to you, I don't do a lot of it, but I will refer to some basic indications there just to keep them in the back of your mind. A combination of the above. Sometimes one of them does not give you all of the answer, and a combination of, say, 2 or more tests are really required to hone the answer appropriately. And sometimes, dare I say it, none of the above. Sometimes we just have to be happy to wait and see for a period of time might be the most appropriate course of action, which can be hard if you're being pressured by the patient. And sometimes no imaging is needed at all, which is even harder, and it's just a matter of clinical management. So first we'll go through a few general considerations before we go down to individual areas. What are the basic things that you need to think about before you even think about, okay, I want to order an ultrasound for this patient or an MRI for this patient? Patient contraindications is something we'll go through. Radiation dose, obviously hugely topical when it comes to CT, and I'm going to go through some approaches to thinking about radiation dose and CT scanning in particular. Availability and cost, very important and very frequently considered issues, but these two things in particular I'm going to address because they can cause decision-making traps, and we don't want to fall in traps with our decision-making process in terms of what we choose to order. So let's just start with some MRI contraindications. Just a reminder, a lot of you are probably familiar with most of these, but it's good to go through them and just re-hone it in the back of your mind. Even specialists sometimes forget, whoops, patient comes along with a request for an MRI and they've got a pacemaker. So it's always good to have that in the back of your mind. Can I order an MRI in this patient? Aneurysm clips. Now, of course, there are some new aneurysm clips that are MRI friendly, but most of them you'd have to be very careful before you're ordering an MRI in someone who has an aneurysm clip. Endovascular stent grafts, recent coronary stents, and by so recent we use about 6 weeks as a rough guideline. Metal in the eyes, and when I say eyes, it's not just the globe, it's the orbit, and the reason is because particularly ferrous metals heat up and the magnet pulls on them, and you can end up causing permanent or significant injury to the globe, blindness even, by putting a patient with metal in their orbit into a scanner. You don't even have to start the scan, they can be lying on the table and get the injury, but it's much worse once you start the scan. So for instance, we would be doing lots and lots and lots of screening plain orbit, plain films in patients who give a history of any risk of having metal in their eyes, or similarly anywhere else in their body where it's potentially sensitive. For instance, now that we're getting a lot of more refugees from the Middle East, for instance, who have been actively involved in wars. I regularly get patients request for MRI and it says, old gunshot wound, and you've got to make sure that there's no metallic fragments close to their spinal cord, anything where if there's magnetism pulling on that metal, it can either heat up and cause injury to tissues, or it can cause injury by pulling. Another example was someone who had an old firecracker injury. They had a firecracker that exploded in their hand, didn't think to mention it, went in and had an MRI of another part of their body and started to complain of excruciating pain in their hand, and that iron filings from the firecracker actually were heating up so much that it was causing blistering in their skin. So you have to stop the scan and get them out straight away. Ossicular implants, again, we spend a lot of time trying to sort out what actually is in there, because if there's any metal at all, it may not be safe, particularly older implants. Some mechanical heart valves, and again, there are some that are okay and some that aren't. There's a book that the radiographers, MR radiographers, use as a guide that lists every known implantable device that people can have, and it's about that thick, and it's always getting thicker. So if ever there's a question and you're not sure, the answer is you can always ring up and ask, but we're always there vetting every single patient who comes as well. Claustrophobia I've got here, that's really one in brackets, because whilst it is a common problem, It's very rare for a patient not to be able to manage an MRI scan with intravenous sedation on board. Now, obviously not all sites administer intravenous sedation. Usually it's small hospital sites or bigger clinics that have the facilities to do that, because you need nursing staff and ability to monitor them afterwards. But I can have patients beside themselves in tears before they've even gone in the room with fear from claustrophobia, and they're as happy as Larry after they've had the scan. It's just a matter of managing it. It's very rare for someone to need a general anaesthetic to have an MRI because of claustrophobia. But even then, occasionally we do general anaesthesia for MRI if it's really significant and really required. Joint replacement's another bony metal where plates and screws and things are fine. Doesn't matter even if you're imaging the same area. Nothing to worry about there. So what about other contraindications? Well, contrast, very important contraindication. What can happen? Urticaria, very common. So hives coming out, a little bit of redness in the skin. Angioneurotic edema, bronchospasm, less common. Anaphylaxis, and of course death. The least common complication, but the most important. For CT contrast, mild reactions run from about 0.5% to 3%, so that's not that rare. Usually things like urticaria and even some mild asthmatic response will settle with antihistamines. Severe response, so anaphylaxis and death, is about 1 in 25,000 doses. So whilst that's rare, it's significant enough that every year somebody is going to die from an injection of contrast in the country somewhere. And in actual fact, that may be several people. Gadolinium MR contrast is less commonly associated with adverse reactions, about 0.5% immediate reactions, and it's been estimated that over 10 years there'll be approximately 1 death per over 5 million doses. So it's pretty rare, but again, it does happen. And as a matter of fact, someone died in Melbourne just a few weeks ago from MR intravenous contrast injection with somebody who had had it before and had no reaction whatsoever, and so it was an idiosyncratic anaphylactic reaction in a suburban clinic. So it does happen. I should say that whilst it can be idiosyncratic and you can't predict it, if someone has had a milder reaction in the past, that increased risk of having a more serious reaction in the future. So if someone has urticaria, hives, or even a little bit of asthma from a reaction, we would not give it again unless there was a very, very strong indications, and you consider pre-medication with steroids and all that sort of thing, and you would really look hardly, is there an alternative to giving contrast to this patient again, because it can be very dangerous. Why might we not be able to give contrast? The renal function. Both CT and MRI contrast require adequate renal function. By say adequate, we use a rough rule of thumb, EGFR of greater than 60, but there is some discretion in that depending on the patient background and the degree of need for the test. For instance, is it the EGFR declined, but is it acutely declined? Are they just recovering from ATN? Are they just recovering from something that has required temporary dialysis, in which case they're much more vulnerable than somebody who's just grumbling along and had a set EGFR, say, maybe it's a 65 for 5 years and it's stable. That's a very different scenario. Could a non-contrast test give reasonable information in the first instance, or would it be useless? There are some tests where if you don't give contrast, if you're trying to characterise a liver lesion on MRI, not giving contrast severely hampers the utility of the study. There are other examinations where you probably get a lot of information from a non-contrast CT that you can then assess that non-contrast study and say, do we really need to give it? And if the patient's got moderately impaired renal function, we might say, look, in an ideal world we'd give contrast, but in actual fact we can be pretty sure that this is what's going on without the injection, and given their kidney function's not great, that's a reasonable compromise. Could we do another test? Could we do a non-contrast MRI and get the answer rather than doing a post-contrast CT? So these are all the sorts of things that we can think about in terms of ways of getting around being able to or not able to give contrast to a patient, whether it's CT or MR. So as a general rule of thumb, we suggest that you check the renal function in a patient who's older than 70. Obviously, if they have a history of renal impairment or some other reason that makes you think they're at increased risk of renal impairment, for instance, if they're a diabetic, we would recommend it. The other thing is, depending on what medications they're on, they may need to have their medications stopped, for instance, metformin stopped for 24 hours or 48 hours prior to the examination in order to minimise the risk of complications. The other one, this little nugget, radiation dose with CT primarily. Plain films obviously is relevant as well, but we'll concentrate thinking about CT given how much adverse publicity there has been recently with respect to CT. You should always think about radiation dose when you're ordering a CT, but it shouldn't stop you from ordering a CT if the CT is the best test for the clinical indication and the patient needs one. There's as in all scenarios, when there's adverse publicity, everybody freaks out and becomes really scared to order them. And in some cases, they may be not ordering them when they really should be. It's a matter of finding a balance, like everything in life. You might be able to choose an MRI or ultrasound versus CT where it will give you the answer, but you may not be able to. But particularly I'd want you to think about ordering an alternate non-ionising radiation test in children and in young adults, obviously pregnant women, in people who are having or likely to have multiple examinations, for instance, certain situations with cancer monitoring or chronic diseases, inflammatory diseases, arthritis, and particularly if you add those two things together, young people who are going to need lots of imaging, the cumulative radiation dose over 10, 15, 20, 30 years is significant. Low-dose CT scanning has revolutionised the way we can think about CT, but it doesn't take it away. It, as a really, really gross, very gross, rough rule of thumb, you might halve the radiation dose that you're giving to a patient with a totally modern low-dose CT scanner with appropriate low-dose techniques applied. That's hugely variable. I'll go into that in a minute. But it doesn't mean that you can still forget about it. Just because it's a low-dose CT doesn't mean you can go and order CT lumbar spines quite happily on 16-year-olds without thinking that that's not an appropriate thing to do. Alternatively, people sometimes get hung up on actual doses, dose quotes. You see the dose tables that are published, and when you have a CT of your lumbar spine, you're going to get X millisieverts, or when you fly from Melbourne to London, you're going to get the same dose as a chest X-ray. Relative correlations are useful to give patients idea and for you to think in your mind ideas, but absolute figures are very misleading. There's huge variability between patients, and there's also huge variability between even the same patient having the same study on different scanners as well. For instance, overweight patients will require a higher radiation dose to have the same diagnostic quality imaging as a thin patient. It's just a fact of life. In order to be able to see a stone in the urinary tract in somebody who weighs 100 kilos, they're going to need more radiation dose than somebody who needs 50. Sorry, who weighs 50. If the CT is the best test though, don't be afraid to order it. That example, CT-KUB in a young person, you might think, oh, they're 18, I don't really want to order a CT, I'm going to order an ultrasound instead, even though they've got classic renal colic, they've got blood in their urine, they've got loin-to-groin flank pain. You might want to do the screening ultrasound to see if they've got a hydronephrosis, but you can still have a mid-ureteric calculus with barely detectable hydronephrosis on an ultrasound. So if the only way to show where that stone is sitting, what size it is, and what the degree of inflammation around the ureter is as a CT, then you can't be afraid to order the CT. It's the best test, and the patient will need it. Something else about radiation dose, the one exception to calculating absolute values is in pregnant women. If they have a pressing need for imaging which requires radiation, then we have radiation physicists who can actually estimate the doses and the relative doses for fetus and mother prior to doing a scan, and then the mother can be given informed consent and advice about what the relative need is and what the potential effects are of having that scan. An example might be, for instance, crude pulmonary embolus. If you had a very high pre-probability risk that somebody has had a pulmonary embolus and they are pregnant, dose estimates and calculations might actually suggest that a CTPA is the best test to go for in first and second trimesters, whereas later on in the third trimester, the dose to the mother and fetus combined as a combined risk and assessment, it might be better to actually do a VQ scan. The other thing to keep in the mind is when dose is particularly sensitive, if you are going to image young people, think about making sure that you're sending to a low-dose CT scan site, because old CT scanners, as I suggested, they're just not equal. And very new scanners, you're always going to have a lower dose for a high quality, given quality examination versus an old scanner. Cost and availability, this is the tricky one. Availability, usually waiting times, at least in private, are not a problem. Obviously when you're going to the public system it can be more of an issue, but I'm really more talking about the private radiology sphere. The other thing of cost, of course, there's an increasing trend to bulk billing, so usually there's a potential to access whatever test you want with bulk billing, and particularly MRI, which has been traditionally the large out-of-pocket cost modality. There are more and more ways of accessing funded or partially funded scans for patients now more than ever, and obviously we're going to talk about or allude to the rebatable indications for MR through the talk as well. I wanted to make the point though that try not to get hung up on is the examination bulk billed or not as being the primary determinant of whether you order it. And believe it or not, it sounds like you wouldn't do that, but in reality, whether it's resistance from patients or a resistance from the doctors in terms of mindset, sometimes that's the primary determinant, and we want to discourage that. Don't order the wrong test because the patient requests it, because it's bulk billed or seems to be cheaper than the alternative, because the patient is claustrophobic, because you think you can get it sooner, whether it's in the afternoon versus the next day, or because it's geographically easier to access. And why do I say these things? Some of these things, all of these things come into a decision, but they shouldn't be the primary determinants. The reason is that the wrong test, by definition, is unlikely to give you the right or the complete answer for the clinical problem. It can result in delays in diagnosis, which at best is inconvenient, and it's inconvenient for the patient because they end up having to come back to get the right test a week down the track or days down the track or months down the track, heaven forbid. It's frustrating for you because you get a report that's inconclusive or recommends another test, and the patient's been waiting for 2 weeks and they're sitting in front of you and you have to say, oh, actually, we need to do another test. It's frustrating for the radiologist because sometimes they have to spend a lot of time on the phone ringing up people when the patient's standing at the front desk saying, we don't have a fluoro machine here, but in actual fact this needs to be done under fluoro, so the patient has to go to another site. At worst, it's dangerous for the patient because things are missed. And also you may unnecessarily irradiate a patient when the best test for them didn't require any radiation, which is not a good thing to do. There might be a lower cost initially, but the correct test usually is performed in the long run. So whilst it might seem a strong argument that either a patient makes or you make to a patient that it's easier and it's cheaper and you're not going to have any out-of-pocket cost to you for this test, but really you have to think about what's going to happen after that if it's not quite right. For example, and this is actually one that I just picked up from clinic the other day, a real live example, I'm not making it up. A bulk billed knee ultrasound does not give you any useful information about the menisci, the cruciates, or the articular cartilage. You would be flabbergasted at how many ultrasound knee requests I get where the GP is hoping to get information about these structures. At most, you can give, vague dissertations on whether, maybe the meniscus is bulging a little bit, but it doesn't tell you anything about what's going on inside the meniscus. And the other thing is is there a Baker cyst? Well, yep, that's great. Ultrasound is great for diagnosing a Baker cyst, but the Baker cyst doesn't tell you what's wrong with the knee. It's a symptom of something going on, mischief inside the knee. Similarly, a suprapatellar effusion. Yep, there's an effusion there, but can't tell you why. So we'll do a little bit more knee things in a minute, but then you're thinking, okay, but the patient doesn't have an acute knee injury, and you're really right up on top of all of your MR rebates, and so you know that the patient is not going to qualify for a rebate. So you're thinking, what else can I do? But in actual fact, if they've got instability and locking, even if they've had it for 2 years, the best test is an MRI, and there's no way of getting around that.